So with that in mind, I think the floor is open for individuals to ask issues from each of our guests. And I will actually start with that for each of them. So there's this huge plethora of what we have. It's all confusing. There's so much to do, so much to learn. Where do we go now? With all that we have and all that still needs to be learned, in fact, where do we go from here? Because obviously there's so much out there, so many options, but still we don't have that ideal app, the in fact ideal instrument, the ideal tool, the ideal website. So where do we go from where we are now? What do we need to do, in fact? So in fact, I'll ask each of you all. Ruth, you want to start?
Yeah, I don't know. So I always start with that. So my humble opinion would be, it's great to have a lot of good people in the room and a lot of good thinkers. And I would say, an Institute of Medicine roundtable is a great thing to be able to address something like that. So, because you've got a lot of stakeholders and you've got a lot of people with good insights. I think we need to be very clear that the purpose of this is to really improve health. I mean, so that's like a really good reason to do it. And I love the whole idea that it can be, we all say, I've never heard anybody say, I get to go to the doctor today. I've got to go. So anything we can do to try to make it engaging, to try to make it more fun, as one of the speakers said, that's a good thing. But I really think, given the mandates that we have in our country about cost and accountability and affordability, that we need to know what the agenda is of our population and of our patients and of our communities. We need to ask them. We need to know what they really want. And that's hard to do, because I know as a healthcare provider, I feel like I know what people need. And so it really is about learning how to have those conversations of listening, which I think is the hardest part of communication, listening to people, because we don't always hear what we want to hear. So I think being very clear on the needs of our patients and our communities, the population, and making sure that our efforts really do align with that. I think making them focused on value, which is a new challenge, because it incorporates cost transparency, which we don't have, is a hot button. I think meaningful use, I love being able to access records, but I can't stand some of what it's making me do. But I think we can look at that as opportunities. And I think the privacy issue, particularly given patients' familiarity and desire to take pictures and to text, is something we can take advantage of, but we need to get on the front end of the privacy and the legal issues and know where to go with that. So I would call those all zones that we could move into.
So from my perspective, we need to think about who is asking where we're going and when. So I'm always thinking that we need to approach these kind of problems in levels. There is a tactical level. Some answers that we need to provide right away. We need to do as much as we can to help healthcare transform into what our vision is. But we also have to have a vision, a strategic vision of what would healthcare look like in 20 years, 10 years or 20 years. And I think that, and I'm going to irritate many of you, I'm sure, that I see a lot of medicine and its application to healthcare to be in a stage of alchemy many, many years ago, where we knew a lot of empirical stuff, but we didn't know how chemistry and physics are really related. And we were not able to develop these wonderful results from ranging from drugs to automobiles and so on, whether they're wonderful or not. until we did that, until we learned the principles. So I think we need to strive for both, doing the kind of work that we need to do right now to implement the patient-centered design, which we heard a lot about, but we also need to understand that it is the principles that we need to derive that will enable us to really make progress in the future. And this would be something that's difficult, and it is a difficult social and economic decisions that need to be made. But I think we have to face it.
I think in healthcare, we're trained to communicate provider to provider. When we're in residency, we do sign out provider to provider. And we've started to move to where we do that engagement with each other to the bedside, so that at least the patient is passively in the room, and if perhaps they're bold enough to speak up, they speak up. And I think what we're seeing with the changes in technology is we have to retrain ourselves to start communicating provider to patient and provider to community in a way that we haven't done, and creating the technology and the systems to allow us to do that. And in order to do that, we have to really go to the end user, we have to go to the patient, and we have to go to the community to understand what the need is, because now they're communicating back to us, and we haven't necessarily been trained to listen. We've been trained to hear, but we don't listen. And I think we hear what we want to hear through our lens of what we're trained to do and to put it into our differential diagnosis, but then we don't hear the relevant thing that we need to hear, because we've already moved on while they're still communicating. And I think we need to start figuring out how we make that paradigm shift in our culture, in healthcare systems, to where we're not always creating things that allow us to communicate to each other as providers, but to communicate with our patients in a way that they can communicate back to us without having to interrupt us to do that.
Questions from the floor?
Hi, Meet Goyle from Northwestern. I'm working with the LitCog study for a little bit right now, looking at their use of technology, so thank you for the shout out there. I was curious, as we get back to the original question of engaging patients and providers, we talked a little bit about technology design. We talked about including community members within the design of the tools, where we sort of try to develop questions together. I'd be curious to hear a little bit about your thoughts about sort of the work that happens before we ever have a patient use technology. What do we understand about why people use technology, and why should they use it for health versus the other social services that they're perhaps gaining out of it? Because it's really hard to make health as sexy as, you know, talking to your family or some of these other uses that we have. And then how do we design tools that then integrate into an individual's lifestyle versus asking them to carve things out specifically for health?
I think this is a great and key question. We did focus groups with sickle cell patients to talk about transition of care for sickle cell patients who were transitioning out of pediatric care facilities into adult care facilities, to ask them what were some of the needs that they had around transitions of care, and then to talk to them about what sort of tools would be useful for them in improving that process. And rather than asking them what technology we could create, we asked them how they were using technology in their day-to-day life already. And what we found was really, really interesting, because without us defining it, they were already doing that. For example, the adolescent who was becoming more independent and going to the emergency room for his pain crisis on his own, he would text his mom to get a list of his medications so that he could relay that information to their provider. A patient who had pain used games to distract themselves when they were having a pain crisis. They used other ways to communicate with their providers when they didn't want to talk to them. So they were already, and what I describe it as, whatever you create needs to be hackable. It needs to be hackable, meaning that the patient who has it needs to be able to make it their own in whatever they're doing and however they're already using technology in their lives. And the thing I love about working in pediatrics is I'm working with the digital natives. I'm working with the kids who are 2 and they know how to use an iPad. And they're teaching us how to utilize that tool if we listen. If we look, if we pay attention, if we listen, we can just incorporate that and integrate that into what they're already doing with their lives. And that's going to vary and be different for each generation and for each person. It's kind of like what Misha said. It's like, what's the individual doing and what's best for that individual?
So let me just make a brief comment on that. We're working at the other spectrum, aging. And aging was a bit more challenging because people approach technology with sort of suspicion, to say the least. And yet, once you ask them what their needs are, we found that one of the most highest concerns was actually not cancer or cardiovascular disease, but cognitive decline. And so we started working on that. What was interesting is that at first they were sort of not sure about how to use technology. We used games and cognitive games that enable them to practice various cognitive skills and being engaged. But also the same computer is used for coaching. It turns out that because we use Skype, and this is work of Harley Jimison, they actually found each other on a Skype and started building communities. We would have never been able to anticipate that. And moreover, if we asked them at first, they wouldn't have said so. So I think it's very important to have an iterative approach. And the patients and users are not necessarily those that know what the final solution for the ultimate solution will be like.
So I'll add one other. Is there anybody in here who likes to waste money? So I really think this whole thing of not wasting money is something that's fairly universal. And I have been, I haven't written it up, but I keep asking a lot of my patients what they're doing to figure out where they can get their medications the cheapest. And it is unbelievable what's going on in that space. And I do share with them the examples I know of that have $4 30-day supplies and $10 90-day supplies and free medications for diabetes at certain grocery stores and how to find it. But there's an entire secondary culture around that. And I hear repeatedly a lot of patients talk about how they feel like every time they go and they just Google something, what comes up has, I'm paraphrasing, a vested interest and is trying to sell them something. So they're trying to figure out how to get the real deal, the one that we all want as well. So I think this issue of trying to move toward that value is actually very smart and is something where technology can have a huge, think of every time you travel, what do? How many windows do you open every time you're buying a ticket? Every time, so I think the ability is there. But I don't see this on the front end. It's not on those medication, holding onto your med apps right now. They're not linked to various costs. And we do know that when you go to 12 different drugstores to pick up your medicines, you could pay 12 different copays or co-insurances. And this is an issue that's on the agenda of a lot of people in our country right now, and it mirrors a national agenda as well. So I think that's a good space.
And also incites user to actually use technology because everybody wants to save money.
Right.
It goes the other way.
Ned?
So my question is about the interface between innovation, the development of evidence, and kind of rapid cycle learning.
Yeah.
So let me kind of come back, because you actually led into it, Dr. Pavel. People who know me, I've spent my academic career in honing methods around evidence-based medicine recommendations and systematic evidence review. And I see two areas where it's not working. Because the innovations are so much farther ahead than our ability to use our tools to summarize and translate evidence into recommendations. We're so far behind. One of them is genetics, but the other is this technological issue. Who would have dreamed, right, that Flappy Birds would have been what it was? You're already saying, who would have known that they would have used Skype? Who would have known that people would be dumping ice over their head to raise money for a disease that they don't even know what it is, but it was linked to some baseball player? I mean, I think that while we're trying to decide what are the harms associated with retail clinics, they are now part of the fabric of healthcare. So how do you look at this issue? I mean, because I'm all about the evidence, but we need to rethink about evidence within the context of rapid cycle learning. Fail early and often, learn from the failures and move forward, because the technology and what people are doing is so far ahead of what we're thinking about in terms of evidence.
Okay, well, let me start on this. First of all, this is so important. In fact, Bill Riley has a very nice slide where he talks about somebody applying for a grant in 2004, getting 2005 for mobile technology. At that time, they have PDAs only. And finally, after all this, recruiting patients, piloting, and so on and so forth, 2012, the thing get published. Now you're laughing. Okay. The study that I reported on was exactly that. Barney Spring applied for a grant in 2004, I think, and the publication is 2012. And the mobile technology that she was using was PDAs, which most young people don't even know what it is. Right? Now, however, we can actually turn it around, because one of the things that mobile technology gives us is very rapid access to information and data. We can collect data in a way we have never been able to do before. As a result, we're beginning to think about randomized controlled trials and evidence gathering as a much more dynamic process, where you can begin to modify the study with principled approaches. So the statistical principles are still applied to actually get much faster turnaround. And but there is also always going to be this little bit of a gap.
I think we've almost run out of time, in fact, but I would just leave us with one thought, which is that there is such a tremendous amount of information about, in fact, out there on each of these individual things, the sickle cell individual, and trying to find the right cost of medications and so on and so forth, in fact. But it's all so disparate. It's all kind of all over the place, in fact. And is there a way that we as a community can try and bring together some organization in this information so that it can become useful? I think I would leave that particular thought with us, in fact, and we will move on to the next one. Appreciate your time.